I'm Sue Stableford. I'm the health literacy and plain language trainer and consultant for the Geriatric Workforce Education Program at the University of New England in Maine. And I'd like to welcome you to a webinar about health literacy and plain language. I'm going to take a minute and put up some slides that will show on my screen. So bear with me for a minute while I get them up. Hopefully you're seeing my screen that has a title page, Health Literacy, Plain Language, and Clear Health Communication. This program will take about 40 to 45 minutes, and there's a pause midway to let you take a little breather. I'd like to first state that I have no financial conflicts of interest to disclose, and also let you be aware of the attribution and how this program is being funded. It's funded by the Health Resources and Services Administration, as you can see on your screen. We thank them, and I thank the Maine GWEP as well. So in order to get started, I'm first going to set up some context for you. And hopefully what you're seeing on your screen is a piece of information that's put out by the Centers for Disease Control and Prevention. You can see the attribution on the bottom. This is a piece of information from their STEADY toolkit. This is a toolkit for older Americans to help prevent falls. So this is a piece about how to do a chair rise exercise. And there are some really nice things about it. It's fairly clear and simple. There is no technical vocabulary. Things are nicely numbered. The bulleted points are nicely numbered. And there are some illustrations on the side that are showing what the text is talking about in terms of telling people how to do this exercise. There are some also things that are somewhat worrisome. One thing is that the illustrations are quite small and they're in green ink, which may pose a problem for somebody with color blindness of some variety. The other piece that is somewhat worrisome for older adults is that there are a lot of steps here. There are 7 steps, which is quite a few. And part of these steps, if you can see them clearly, are to integrate a pattern of breathing along with a pattern of standing up and sitting down. So this is actually a little more challenging than it looks. Some of our clinical providers asked if we could simplify this. And so we did. And so the next slide I'm going to show you is what we did to this to make it even clearer and to design it in even more clear plain language. So here is the redesigned piece. Again, this is about the chair rise exercise. You can see that there's more white space. The illustration is larger and brighter and bolder and shows an older person. The steps have been reduced to 4, and there have been 2 write-in places. There's a place for a clinician to write in a patient's goal up at the top, and there's also a place for the clinician to write in directions at the bottom. So we simplified this into a plainer language version of the instructions to make it more appropriate for clinical use. So this is what we're going to be talking about this morning. Why did we go to this trouble? So we're going to be talking about what is health literacy all about? What are the health literacy, numeracy, and literacy skills of American adults? What are the impacts of limited health literacy skills, how we can address the challenge with 3 evidence-based techniques, and finally, I conclude the session with what you can do now. There are 4 slides at the end that will give you some direct application tips. So thinking about the slides you just saw and how we simplified something into plain language and made it more clinically useful, let's start with backtracking a little and talking about health literacy. So what is health literacy? Well, lots of people would give you lots of different answers. There have been many definitions over the years, but when it comes down to the basics, it's a communication concept. It's an idea of people understanding each other in a health context. So it involves an audience, which is likely patients, caregivers, and family members the messages that we need for them to understand, whether they are text messages or web-based or electronic or video or however they're presented. And then there's us, the messengers. Communication always involves a larger context of time, place, knowledge, and skills. So the background knowledge that patients bring is one piece of knowledge. The knowledge we have is another type of knowledge. And again, the skills are different, but the skills between us when we're communicating usually involve speaking, listening, reading, and writing at a minimum. So health literacy involves who has these skills, how do they have them, and how are they used? So we have some information first about our audience. What does health literacy mean from an audience perspective? It means what abilities do adults, our patients, families, and caregivers, what do they bring to the table? How well do they read, write, compute, or do math, understand and evaluate, communicate, and then use health information? Possibly the information we give them, possibly information they learn from many other places. Interestingly, we have some information about adult literacy skills. Now, this national survey goes back to 2003, but we also know that even though this data may seem old, it has not changed very much. It's often called the NAAL, N-A-A-L, and it was done by visiting 26,000 American adults in the places where they live. This was a representative sample of our adult population ages 16 and up. And what you're seeing on the screen are the results of everyday literacy skills, the prose literacy skills that they demonstrated. Now, adults were asked to demonstrate skills of different levels of complexity. And you can see those levels on the bottom of this slide. First, they were asked to do very, very simple skills, below basic tasks. If they could do those, they moved on to basic, and then intermediate, and then proficient. Once the 26,000 adults had been individually interviewed, the results of all the tasks they were able to do were compiled into some final national scores. And here's what we learned. And here are the numbers that go with these scores. We learned that a total of 93 million adults, or 43% of our American adults, had basic or below basic prose literacy skills only. Now, this means they were reading at a level, reading information written in sentences and paragraphs, everyday reading, newspapers, all kinds of flyers, maybe our health education handouts. They would be struggling to read most of the information that we were giving out or that they had acquired in some other fashion. Notice also that only 13% of our adult population had skills that were considered proficient, which is a very small minority of people. And there were another 2 to 5% of folks that did not speak or read English well enough to comply with the test, with the tasks at all. So we're really headed toward nearly 50% or half of our adults reading at very, very limited levels. The same survey also measured people's math skills, which they called quantitative literacy. And notice again that only 13% had proficient skills, and even more, 55%, and again, climbing to almost 2/3 of American adults had very limited math skills. And I'd like you to think for a moment about the implications of that for managing in a healthcare environment in terms of the kinds of tasks people are expected to do, all the way from taking medicines accurately, even titrating medicines, for example, when they have to increase or decrease a dose, perhaps using an antidepressant of some kind, or Coumadin or warfarin. And beyond medicine, we ask people to do all kinds of other tasks, from understanding their blood pressure measurements, using a BMI chart to figure out if their weight needs to be reduced, from reading food labels, etc. So we ask people to do many, many math tasks, and only 13% are able to do these with a proficient level of skill. There was also a special section on the NOL that measured health literacy results. That is, people were asked to do tasks, both math tasks and reading literacy tasks, in using examples from health and medicine. And only 12% of adults were able to demonstrate that they had proficient skills in this arena. That means that 88% of us have some level of limitation in our health literacy skills. Here's an example of a proficient task. People were asked to calculate an employee's share of health insurance costs for a year using a table that shows how the employee's monthly cost varies depending on income and family size. So you can imagine in your mind that they were having to interpret a cross-hatched table, which is tricky, reading down and across at the same time to figure out, according to the size of their family and according to their monthly income, what their share of health insurance costs would be. Not surprising that only 12% of adults could do this. And also not surprising that so many adults don't choose the right health plan because this task challenges them and many people are unable to do it. Our most vulnerable population groups are pictured here. And just to list them, here they are. Adults who are older, especially ages 65 and older, but literacy and quantitative literacy skills actually start declining at age 50. So the 60-year-olds read less well than the 50-year-olds, the 70-year-olds read less well than the 60-year-olds, etc. Now, some of this might have to do with a decline in cognition, in mental capacity, but it's not entirely clear. But do be aware that those of us that are serving elders, the older population, this population is especially at risk for limited literacy and very limited health literacy. And the other populations that are listed here as well: Hispanic Latino folks, immigrants who may speak English as a second language or not at all, people who are poor, and people managing a chronic physical or chronic mental condition. Many patients, not to mention their caregivers and families, may fall into more than one of these overlapping categories, putting them at high risk for limited skills. We had some updated data to the 2003 literacy data done in this country from the study called the PIAC, and what you're looking at is the cover of the report. This was an international survey that measured many of the same things that our national literacy survey measured, but they measured it among many countries in the world. They scored this differently. They scored it in 5 levels for a total of 500 points. But the takeaway is that overall, our 5,000 adults that were measured did poorly in comparison to many other countries. Keep in mind, again, that higher scores in this survey were better. So scores at levels 3, 4, and 5 were better than lower scores. But notice again that for literacy, everyday reading skills, fewer than half of our adults could read at those higher levels, and only a little more than a third of them could perform math tasks at those results. So these are indications that the results we achieved in 2003 were probably right on target. A large majority of our American adult population struggles with limited literacy and limited math skills, particularly if they're older adults. So let's transition to messages. We talked about the audience. We're moving on to the messages. What do we ask people to do related to their care, and perhaps to their care of children or grandchildren or other family members? We ask them to manage insurance and bills, many kinds of medical conditions, both acute and chronic. We ask them to get preventive care and stay on track with that. We ask them to manage sometimes very complex treatment regimens with multiple medications along with daily routines of some kind. We ask them to manage health habits, eating healthy, getting to bed on time, exercise, etc. Many people are managing behavioral and mental health challenges, care coordination, respond to quality surveys, and the list goes on. So when you look at this list in its entirety and think, wow, this is a lot that we're asking people to do, and many people are needing to do this with very limited skills on board. So let's turn to the messengers. That's us. How well are we doing and our health systems doing in communicating? And again, considering the limited skills that millions of people bring to the table and the overwhelming number and complexity of the tasks that we ask them to do, how well do we communicate it? How well are we doing? Well, the sad answer is not too well. There are literally thousands of research articles showing that most of the information that we give to people, either electronically or in print or however we're distributing it, including patient portals, most of it's written at very high reading levels. Our verbal communication is often too fast, using medical language that people do not understand, and there are few systems in place to assure patient and family understanding and the ability to care for themselves. I think the sign says it all. How do most adults respond to what I would describe as a quagmire? I think the pictures tell the story. The fact of it is that health literacy challenges all of us. Now, again, there are different extents of the challenge. When we're dealing with a college-educated population, they may have more skills on board to deal with the many messages and the complexity of the care that we're asking them to assume. But often they are stressed if the diagnosis is new, if the surroundings are new, if they're in unfamiliar territory. Even our well-educated folks will be challenged with sometimes limited knowledge. And as you've seen, millions, if not the majority of our folks, have limited skills, time, and resilience. And on top of it, there's often poor health to begin with, vision or hearing challenges, mobility challenges, and many people lack a support system. So the communication challenge affects us all. So here's a way that we might simplify what this challenge is. On one side is what people bring to the table. And again, they may be in a situation of great duress. On the other side are the complex systems and communications that we share with people. Often there are strong emotions surrounding our communication efforts, and it results in a really large health literacy challenge. So this is a big challenge. Health literacy is essentially a challenge with two components. What do people bring to the table and how do we respond? And for right now, it's not going really well. Here's a shorthand way of thinking about the communication gap. Average literacy skills are about grade 7-8. That is not meaning that adults communicate like middle schoolers or junior high schoolers. That's not what we're saying here. What we're saying is that their average reading skills, literacy skills, are limited. Most of our health information, when it's measured on a readability scale or at a 10th grade reading level or higher. Most of our consent forms, in fact, are at college reading level. And so are many of the brochures we give out about complex topics that we want people to read all about, perhaps preparation for surgery. And again, just to repeat it, verbal teaching is often done quickly because we have limited time and people hear it as a foreign language. And in fact, medical terms are foreign language to the average person. There's a serious impact from this communication gap, from what we ask people to understand and use and the way we communicate it. The impact is serious. For people with limited health literacy skills, they typically have a low understanding of the information that we share. They have lower knowledge and uneven adherence in managing their chronic conditions, which leads to poor outcomes. They have decreased knowledge and likelihood of getting preventive care, an increased risk of faulty diagnosis. And for elders, older adults, particularly the people that we primarily serve, there's the risk of increased hospitalizations, costs, and deaths. Now, this slide summarizes about 30 years of research. And if some of you would like to see some of this research, that's available. There's also increased system risk with this miscommunication or communication gap. There's the challenge that patients may not appreciate our efforts, which leads to lower CAPS scores, those scores which measure how well we do. Some hospital systems call them Press-Ganey scores, but this is the consumer assessment of how well we communicate with them, both in office visits and in the hospital. And we know from reviewing those scores that those communication scores, pieces of these scores, are often quite low. We have suboptimal outcomes, which can lead to hospital readmission, which can in turn lead to increased costs. And finally, there's an increased likelihood of malpractice claims. So I'd like to pause here for just a minute and let you think about what we've just covered and ask you to think about what the limited skills that you've learned about for adults' literacy and health literacy. What does this mean for your work? How do you understand this and the impact that it might be having on the work you do or on the system that you work in? And are there any efforts underway to address limited literacy and limited health literacy skills for patients, families, caregivers, and perhaps for some of the staff in your institution, if you work in an institution as well? So let's continue and let's transition. We've talked to a fairly great extent about what the problem is. Let's talk about solutions. We have 3 evidence-based solutions, and here they are listed on your screen: plain language, plain numbers, and teach back. Plain language is more than words. You might have heard the unfortunate phrase, oh, we're just going to dumb everything down. Nothing could be further from the truth. Plain language really means integrating a whole series of elements in a document or in a presentation of some kind. Again, no matter what form of communication you're using, it means limiting the content and focusing on the most important points, organizing and structuring either your verbal communication or your web communication or your portal information or whatever it is. Put those key messages up front and keep your chunks of information small so that people can skim and scan and find them easily. The writing needs to be clear, using familiar terms and as little medical jargon as possible. If you need to use unfamiliar language for whatever reason, explain it. And there are other techniques that are integrated as well, such as using personal pronouns. The design of something is critically important so that people get the messages quickly, so that they can, again, skim and scan. And always we need to be sensitive and inclusive in the broadest sense of culture. So let's take another look at the plain language example I shared early in the presentation. Here was the revised piece that we created at the request of a clinician who wanted a simple, clear explanation to give her patients about the chair rise exercise. And notice that the qualities that I just listed are reflected in this piece. The content is limited. The organization reflects the way that the physician wanted to use it in her clinical practice. There are clear, simple terms. The whole complex breathing in, breathing out piece of it was eliminated because it wasn't essential to what somebody needed to do. The design enhances the message. It's big and it's bold and it's bright. It's appealing and it's, again, down to the essentials. And finally, the design, the illustration, the image reflects the target audience. It is not inclusive of all populations. It does not show someone with brown skin, for example, It shows somebody with white skin, but in this particular instance, it's not possible to show multi-ethnic representations. It became most important to be bright, attractive, clear, and represent an older audience. And this is what the picture does. So again, this is how plain language incorporates many elements. Let me show you another example just from simplifying text. This was the original start to a letter from a patient relations specialist in a medical system who was responding to a patient complaint. And this is how they started out. Look at the complexity of this as the initial couple of sentences. I'm writing to you in my role as patient relations specialist in the Office of Patient Experience at blankety, 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 blankety Medical Center. I am a contact person for patients wishing to share feedback about the quality of care they receive at our organization. Now, by the time someone, if they had limited literacy skills, they would never get through this in the first place. But even someone with good literacy skills would struggle with all these terms. Patient relations specialist, the Office of Patient Experience, the blankety, blankety, blankety Medical Center. And remember, this is a letter. So the letterhead often includes almost all of the beginning of this sentence. If they want to identify the Office of Patient Experience, that can be done at the end. And the Medical Center logo clearly identifies where this comes from. So here's a rewrite of this language. I am a patient relations specialist responding to your letter which shared concerns about the care you received here. Simple, clear, short, right to the point. So nothing about, we shortened up. Instead of talking about the quality of care they receive at our organization, I'm responding to the care you received here. So again, this is an example of literal plain language reducing complexity to simplicity in the words we use as well as how we frame sentences, keeping them short and simple so people can get the message right away. Here's a wonderful summary of what plain language involves. This is on the CDC website. I would encourage anybody to download this. It's a wonderful poster that comes in many sizes, and it summarizes very quickly what it is that we all need to do to help our patients understand. Organize to serve people well, choose our words carefully, and make information easy to find. Those are the 3 key points. And then, of course, there's some sub-bullets under them. We also need to use plain numbers. As you saw, people struggle even harder with their math ability than with their reading ability. So I say using plain numbers means this. When you use numbers, use whole numbers as much as possible, not decimals, fractions, or percentages. Now, this is not always possible. Of course, if someone's taking a temperature, they need to use that decimal point. And there's many other examples we could give where that's necessary. But when possible, use whole numbers. Do not ask people to do math. Do it for them. Don't ask them to compute 5% of their body weight. You do it and figure out what that is and tell them. When you provide numbers, tell them what the numbers mean, whether it's their blood pressure numbers or their blood sugar levels or whatever it is. Tell them what the numbers mean, particularly when you're teaching them to use a device like an inhaler, for example. Tell them what the numbers are, what they need to be, and what they mean. Write numbers like telephone numbers, like digits, not words. It's much easier to see numbers when they're written this way. Be aware that sometimes the unfamiliar measurement units are just as confusing to patients as the numbers themselves. If people were born in the United States and went through the school system here, they probably did not learn the metric system. So they don't always know what those metric measurements are. Keep graphs, charts, and tables simple. Again, remember that most American adults, most of them, majority, could not read a crosshatch table. that required them to read down and across at the same time. So keep things simple. Try and keep tables running in just one direction if possible, and keep graphs simple. Simple line graphs or simple bar charts are fine. But beyond that, people start to get confused. And finally, when you're explaining risk, which you might do with patients, keep the denominators the same. Say if you're using 100 or 1,000 as the denominator for a risk situation, continue to use that all the way through. Don't change midway. So here's some examples that integrate plain language and plain numbers. These instructions come from medical discharge instructions that are handed to patients at a well-known medical institution. For hydrocortisone, the instructions say apply topically. Now, why would we use that language? What does that mean? Topically is a 4-syllable word, and a lot of people don't know what that means. Why wouldn't we say put on your skin, rub on your skin, smooth on your skin, or just apply on skin? Why do we make it hard? These are the instructions for a statin that came in 20 milligram tablets, and we tell people to take 0.5 tablets. How many tablets might you imagine that they take? Perhaps 5. Again, people are confused by this kind of decimal representation. Why don't we tell folks, take half of 1 tablet? That's what these instructions mean. Here are the nitroglycerin instructions that are typical. And look at what it says on the bottle. Nitroglycerin 0.4 mg SUBL. Dose 0.4 mg. How would the average person know what any of that meant? Why wouldn't we say place 1 tablet under the tongue or under your tongue? When you have symptoms, place 1 tablet under the tongue. And then there are directions, of course, that go on from there about repeating these if the problem still has not subsided. But again, how would people have any idea what some of this medical language meant? And they get confused. We know they get confused because the research literature is full of studies that talk about how people misunderstand medication instructions. And these are just some indications of why that might happen. So the third evidence-based opportunity for us to help people is to use teachback. And probably many of you know what this is, but it's the only way to assure understanding of what we have taught verbally. So we teach, or an educator teaches, and then we invite our patient or family or caregiver to tell back or show back in their own words what the instructions are that we've just given them. And we listen. And if there have been misunderstandings, which is very likely, we can reteach before that person walks out of the office or out of the hospital. So the important piece about this is that this is an invitation. We're not here to grill anybody or to make people feel shamed that they're not good learners. What we are doing is checking ourselves. So we might say, we need to take the responsibility. We might say, Mrs. Smith or Mr. Jones, I teach this information every day, and I want to make sure I haven't left anything out. Can you tell me what you'll do when you get home with this new medicine? Or perhaps, can you tell me what you're going to tell your family about our visit today and what you need to do to take care of yourself? So we assume the responsibility for having done the teaching and invite the patient to share in their own words. So here's an example. Could teachback have helped Mr. XYZ? Mr. XYZ is a real patient. He was a very well-educated gentleman that went to a medical clinic in New England. He actually spoke 5 languages, but English was not his first language. He came to clinic because he had a very bad ear infection. He was in pain. And he was prescribed Flonase, which he went home and used in his ear because he had an ear infection. He called many days later, wondering why the infection hadn't cleared up. Suppose the clinician had said to him, Mr. XYZ, I want to be sure I was clear with my directions for Flonase. Can you tell me how you use it when you get home? No one checked in the clinic, and no one checked at the pharmacy that this gentleman knew how to use this medication. So let's transition once again. We've talked about the issue, the problem. We've talked about some of the evidence-based solutions, the major 3 evidence-based solutions that we can use. And now let's talk a little bit about some supports on a larger environmental system that support us getting on board and actually taking action. And I'm going to make this one slide again that summarizes many decades of effort. The federal government has made many efforts to drive the use of plain language, starting way back in 2010 with the Plain Language Act that requires all federal agencies to use plain language when communicating with the public. And if you take a look at federal websites from 2010, if you still have an old computer and have that information and compare them to what they look like a decade later, you will notice a huge change in all our large health-related websites. They've done a great job. The federal government has also published a national action plan that includes, and many federal agencies such as the CDC and the National Institutes of Health and AHRQ, the Agency for Healthcare Research and Quality, all 3 of those sites have published extensive information and training programs on their sites. I invite you to check them out for incredible information about good practice tools for understanding health literacy and using plain language, as well as training programs, as well as many documents that show you how to do it. The ACA, the Affordable Care Act, built in many reforms to the system, including, as we mentioned before, a cost for hospital readmissions within 30 days for patients returning with certain diagnoses. That means that discharge planning and teaching have to be excellent so that these patients do not return to the hospital, for example, within 30 days with, for example, heart failure or pneumonia. And there are other chronic conditions that fall into these categories as well. The ACA also initiated other reforms, which are embodied in CMS regulations, the Centers for Medicare and Medicaid Services. There are regulatory standards put out by the Joint Commission that requires all patient communication to be in language understandable to the patient. There are cultural and linguistic access standards that require the use of plain language, and many more. There are academic and professional practice standards. Many of our health profession students now, including physicians, PTs, OTs, nurse practitioners, physician assistants, dentists, etc., and many more that are learning about health literacy in plain language in their academic programs and required to learn more about it. Some of them tell us that they really enjoy this and think it's a great idea, but they don't see it modeled when they get into their clinical practica. So it's important for all of us to get on board and be sure that we're modeling the kinds of things that they're learning. And finally, we have some excellent examples across the country of systems of care delivery that are doing an excellent job. So I'll just mention a few. Kaiser Permanente out in California has addressed this issue. Mayo Clinic has addressed the issue. Intermountain Healthcare in Utah, Maine Health in Portland, Maine, and many more systems across the country have gotten on board with teaching, with their patient education staff, creating plain language communications and teaching professional staff about how to communicate more effectively with all patients across the spectrum. We might ask, do these solutions work? And there's a great deal of evidence that they do. This is perhaps one of the best summaries of all the evidence that was published by the National Academy of Medicine in 2018. This is online and easily accessible. The Appendix C in this particular document, Building the Case for Health Literacy, documents the research and makes the case for taking action in all these different ways. It makes the fiscal case, the behavioral case, et cetera, et cetera. You can see on your screen all the different ways that they approach this and ask, does making the effort and making an investment make sense from all these different perspectives? And the answer is yes, it does. And even though health equity is at the bottom of this list, it is not the least of the issues involved here. We know that addressing communication challenges is a major part of addressing health equity, which is now a very large topic across the country. So it is worth the effort because it will take a lot of effort to get on board here. Consider the quality and the safety of care. This is a huge patient safety issue. Consider person and family experience and engagement, which all health systems strive to improve. Again, diversity and inclusion require that we address this. There's a cost benefit factor here. It's an investment and it's also a reward for systems that get on board. It seems to increase provider and staff satisfaction. Most providers want to know that they've done a good job and that they're working in a system that cares about them as well as patients. And finally, this is a competitive issue. Systems that get on board are leading the way. I want to be sure you're aware of this from a safety perspective because it's so important. This was a national report published by the Institute for Healthcare Improvement just a little over a year ago, in which plain language is embodied throughout the report. And I've given you one quote and cited the page number here. It just says to ensure that materials use plain language and are designed and validated for varying literacy levels and languages. So this is a major component, again, of patient safety. So let's sum up. As you've seen, millions lack the literacy and health literacy skills needed to manage in our complex healthcare environment. We can help using 3 evidence-based techniques. This has a payoff. We build patient trust and loyalty, which is really important to effective care. We can meet regulatory requirements and help build a healthy organizational culture. Again, whether this is a large institution or whether you work in a clinic or a private office. And national efforts and trends support this work. The following 4 slides are tips for you to try and use when you can, and you can pick and choose. Likely you're not going to implement them all right away, but these are things you can take advantage of as it's appropriate for you. So here are some tips for when you hand out information, and I won't go through them all. I'll let you read them through on your own time. Here are some tips for when you need to write materials, whether you're writing instructions or letters or emails or putting information in a patient portal. Keep it organized. Imagine the person receiving it and organizing it, and use everyday language as much as possible. When you give verbal instructions, here are some things you can do that will help everyone, patients, caregivers, and family members. And finally, when you're using numbers, remember to keep them simple. Thank you. And thank you for all you do to provide care and have taken this extra time to provide really effective communication for everyone with whom you come in contact.